Okay, thank you again. So a couple of my disclosures. I'm not a superstar. In this room, I have two people who I consider my mentors. One is Dr. Patsak, because I have learned a lot about pheochromocytoma and paraganglioma after 6 years that I've spent at the NIH, and we often refer to this as our golden time years. And Dr. Ross is there in the back, who was my professor of pathology. He is one of the presenters here. He is former chair of a department of pathology over in Albany Med, built a great thing, and will forever be my mentor. So it's a special thing. So I'm going to try to do the very best here. And finally, I hope to have a chance to talk to many of you today. If I do not, or when I will not show up tomorrow morning, is because I have to fly out to Washington, D.C. for a wedding of a child of a family who hosted my wife's family when we just came to United States, when they came to United States. So I just couldn't say no. So at least if I don't show up, please do not think that I just decided to slip in. Okay, good. So now we're going to talk about surgical approaches. And it's very simple. When you have a hammer, everything is obviously I forgot what that word is, but everybody knows what nail is. And that's indeed, this is the same picture of the NIH that Dr. Patsak has shown. This is where truly groundbreaking research has happened. This is where a lot of the expertise came from, and this is where I learned so much from. Just to be perfectly humble, I had this is my bipartisan slide. So it just shows that I have no, although I do have a party affiliation, I will not disclose. Okay, let me move through. Okay, disclosures. I have no disclosures other than the fact that I'm a surgeon. And I think my disclosure and my biases are very well reflected in this very slide. This was something we published in Nature Reviews Urology with one of my former mentors, Dr. Linehan, where I said routine adrenalectomy in renal cancer is an antiquated practice. And what I meant is that removing an adrenal gland is a bad idea unless adrenal appears to be affected. And even with those that are affected, in cases of pheochromocytoma, we're still safe, and we should try to save. And I will give you, hopefully, a compelling reasons why. Since my talk is labeled as paraganglioma, I can honestly tell you that there are plenty of evidence, and I do know that there are plenty of speakers who will talk about other things, where we will talk about everything in the belly. And I can tell you that those things we can remove, no matter where they are, they can be removed. I do not go into a neck. I probably can, but I probably shouldn't. There are some paragangliomas that can either be treated surgically, with ablation, or with radiation. Bottom line is, if there is something in a world of pheochromocytoma that can be treated surgically, or can be resected, or can be treated with definitive therapy, one should always consider to do it. There are some cases when there is really no role for surgery. And again, this is just something Dr. Bernstein mentioned earlier. This is a good example of where these things can occur as paraganglioma anywhere along the sympathetic or parasympathetic chains. They will have different genetic causes. They will have different biochemical profiles. And I admire something that I have learned from Dr. Patsak when we only knew 4 genes back 10 some years ago, when we would look at the biochemical profile of the patient, and we knew exactly what gene it was. And it just is very reassuring to understand this whole genotype, phenotype characteristics, and the biochemical profile is very important for us to know what exactly we deal with, where we look for these tumors, how we look for them, and we already talked about when and how we screen. So the paraganglioma surgery is not an uncommon scenario. There are few case reports, but all combined, there are over 8,000 series or small case reports that have described removal of paraganglioma from here and there. The reason I showed this slide, it's not that surgeons are so good that they've done 8,000 successful operations or so on, or many series is the fact that these paragangliomas can appear anywhere and if possibly can be removed. The management, as I mentioned, and I put it in bold for those who did not appreciate it, it says resection if possible. And I mean it, and if possibly, just because I'm a surgeon, this is the case where things are a nail. If it's solitary, if it's a legal volume disease, meaning there are few spots. If we can resect them, let us resect it. And again, as Dr. Reed already mentioned, the laparoscopic is compared to open. And again, as I mentioned, the RFA, cryosurgery, stereotactic, or angioembolization, all these things have been tried, all these things have been published. There is some success with this. Again, follow-up is much more challenging with these patients when you have embolization. We really have not established the success after embolization or ablation, meaning that after we fry or freeze the tumor, we really do not know how to best image them, as we don't have series that have an excellent follow-up with tissue removal. So just because they change imaging characteristics does not mean that these tumors do not exist and some live cells don't exist, and we don't know the long-term results. Everybody understands that adrenals sit above the kidney, and I don't need to go over too much of a physiology, but as I would like to point out, the medulla, or the center of the adrenal gland, is only one of several other layers that present in the adrenal, and I'm building up a case for adrenal preservation, that just because somebody is going to have a pheochromocytoma or tumor of that red box, it does not necessarily mean that the other innocent bystanders need to go. In fact, just because these layers came together in one organ does not mean that the presence of tumor in one of these layers mandates removal of the things around it. Just because somebody who has a kidney cancer does not really mandate that I must remove the colon and the spleen and the pancreas just because I'm removing a kidney. I look at the adrenal the same way. These are embryologically distinct layers that have come together, and medulla certainly just happen to come from very different cell types. There is very little communication between these layers of medulla and those that are outside. The reason I showed this slide for everybody, patients and surgeons and non-surgeons, is because when you look at the blood supply of adrenal glands, as you can see, I'll step away. These are adrenals, and these are the various blood supplies. And one must appreciate that it looks complex, but in real life it's much more complex. In fact, this picture does not do it justice. So the reason I state and I point out this, that you can perform adrenal sparing surgery even when the surgeon comes out and would tell you, oh really, I really didn't see a vessel that I could spare. I really didn't see a vein that it could drain from. These adrenals find a way to be supplied, to live, and to drain. And it's very important that we don't just look at a major, what we call gross structures during the surgery, and we say, oh, I just took the artery, I have to take the whole adrenal. It is not the case. There are tiny little capillaries, tiny little arterioles that supply and drain the adrenal. In my personal experience, I have saved adrenals when I took out all the major arteries, all the major veins supplying it, left it attached to a small piece of fat of the kidney, and then years later having to come back for a kidney surgery or something else, and unfortunately that was a nature of many patients. You can see this beautiful, healthy, nice, small adrenal remnant, even if you don't quite sure if that's what you see on a cross-sectional imaging, CAT scan and MRI. And this picture is probably a good example of what I'm talking about, the innocent portion of the adrenal. One can see this reddish, rubbery type of a tumor in the middle, and you can see all this extra tissue here and here that have nothing, absolutely nothing to do with a pheochromocytoma. And removing this tissue makes absolutely no sense and will never make any sense to me. When we manage these pheochromocytomas, there are rules of 3Ls. I came up with these 3Ls just because I needed to formulate it for my residents when we teach. And the 3Ls is to localize. Please make sure when you deal with the pheochromocytoma or paraganglioma, please localize them. Know where they are. And I love the earlier example that when somebody comes in with a paraganglioma in the neck, please make sure you don't have any other paragangliomas. Please make sure you don't have a pheochromocytoma. Just getting them ready for surgery is not what surgeons should do. Please complete the metastatic workup. Please complete the imaging workup. Look for extra-adrenal diseases. The reason I say that is because in cases of some of the familial syndromes, it's extremely important to understand where they may be. And as we learn, more and more of these cases are familial. More and more of these patients are syndromic. There will be time when likely we will not be using the word sporadic. I hate to disappoint my own self, but as a surgeon, it's much easier to deal with patients that are sporadic. Just because we can't find a gene doesn't really make them truly sporadic. And the third one is lots of alpha blockers. So please use alpha blockers. If it's too expensive, calcium channel blockers, but bottom line is, please do it prior to surgery. This is a review that we wrote with two of my former residents in urology practice. Why not remove the entire adrenal gland? And this was an effort to communicate to urologic surgeons, because I can only influence urologists who are so happy to do this quick laparoscopic removal of the adrenal if they find something that needs to have thing. First of all, there are bilateral pheochromocytomas that are not uncommon, or I should say they're quite common. In hereditary syndromes, everybody understands that the risk of bilateral or risk of adrenal disease or pheochromocytoma on both sides, which means bilateral, is quite high. And we can see that it occurs in MEN, VHL, and many other. You can also see that even APA, which is aldosterone-producing adenomas, even those diseases that can happen in bilateral or in both adrenals. This is another list of many reasons why adrenal gland is not safe. Just because God gave us two adrenals does not mean that we can yank out one and then get going on a second one, just because it's fine. Yes, indeed. If you look at prevalence per million, in this row, they're all low. 8 cases per million, 40 cases per million, 47.5, I don't know who came up with that number, 6,000 cases per million. But those are all the things that may affect adrenals. And when things are affected, these adrenals are not safe, these patients are no longer safe, and essentially they lose adrenal function. And another reason why adrenals are not safe is that this is the older paper by Newman and his group from 2002. And as you can see, this is a paper when they said that, hey, the non-syndromic pheochromocytoma is not your 10% anymore. It's this much more prevalent. This is a time when they've estimated that people with no family history and with now knowledge of all the additional many genes that we've discovered on a germline testing was already over 20%. So very briefly, pros and cons of partial adrenalectomy. So what is partial adrenalectomy? Is removing the tumor from the adrenal, leaving the rest of the adrenal alone. Of course, many surgeons will look at the films and say, I just can't do it. It shouldn't be done. Yes, it can, and it should. So very quickly, partial adrenalectomy can preserve the function of those other layers that are important. You can avoid adrenal insufficiency or Addisonian crisis. And also must estimate the risk of new recurrence. Of course, there is always a risk, but it's safe, and I will show you better data as well. Steroid replacement is not physiological. We do not produce steroids throughout the day at a certain amount. We produce it according to our needs. So just because we give patients steroids twice a day for a replacement, either prednisone, florinef, without, this is still not physiologic, so don't get stressed. There are numerous drug interactions, numerous side effects, and this is a very classic study that has shown that there was as much as 4% death from Addisonian crisis of those patients who had bilateral adrenalectomy. You take the adrenals off, no matter how much you educate this patient, somebody will invariably get sick on a cruise, or somebody will get a virus when they didn't have their prednisone or too far, and these patients die from Addisonian crisis. Or one surgeon will just forget to give some sort of steroids. The preservation of adrenal cortex is not novel. It has been described first time, as you can see in Urology, in 1982, when the surgeon described a portion of left cortex was left in adrenal bed, although the arterial and venous supply has been ligated. So ligated meaning cut off. He said, well, I leave it a piece. Who knows? But interestingly, successful autograft was documented 15 years post-operatively. So 15 years later, somehow this thing survived, attached to God knows what, to a piece of fat. But as I told you, these things live. This is another one from 85, where bilateral pheochromocytomas were resected. So, and again, the function was normal 3 years after resection, and this is in the MEN2. So in different pathologies, this is done, this could be done. NCI, of course, the earlier series in 2005 has shown that you can do partial adrenalectomy. We were the first ones to describe this technique using robotic approach, and then these are probably very reflective imaging of what can be done. Even though on the images, you can see the two areas on the right before. You just see two circles. You really don't even see normal adrenal gland. You can find it. It's compressed, it's hidden, and you can see this is the same patient who was saved both adrenal glands, despite the fact that this was a very challenging case. We did it with the robot and the whole thing. Most importantly, this patient avoided lifelong steroids. And we have then published the whole technique on how to do it, and believe it or not, at some point, this was even the best video presentation at a major national conference. One will say, okay, fine, you can do it technically. Can you save enough function? If you can. This is a paper we co-authored with Dr. Patsak and several others from the NCI, when we identified the patients that had a long enough of a follow-up of over 9 years. There was not a single metastatic event, just when we saved the adrenal gland and just removed the tumor. Some had developed local recurrence. These local recurrences are not because we forgot to take out a piece of tumor, because these patients often form what is known as de novo tumors. They are predisposed to form these tumors. So there have been recurrences, and only 3 out of 26 required steroids. And I will show you what these numbers are looking like at the more recent publication. We have also taken a look and seen what happens when you already had a surgery on both sides. Who are the patients? And bottom line is, we have learned that if you do the surgery, not at the same time on both adrenal, but if you do one side after another, you're more likely not to require steroids, or I should say you're less likely to require steroids. And intervention should be done before the lesion grows to 4 centimeters. And we can observe some of these patients as well. Then we did a big review that we published in Journal Urology in terms of how we did it. We found over 400 articles. We wanted to validate. We wanted to really bring it across to so many that this can be done. We pulled all this series from all these different places, and you can see different numbers from different institutions all over from the world: Sweden, US, Japan, Germany, Austria. And what we have found that there were already several hundred patients that were treated with partial adrenalectomy or saving the adrenal gland. It was safe. The transfusion underlined stat 2 out of 231, less than 1% required transfusion. Perioperative complications in less than 10%. And remember, this is on par if you were to remove the entire adrenal gland. And most importantly, the recurrence was also quite low. The 2019 paper that we're about to submit from the NCI, and we just got it ready. It's interesting. You look at the list of authors, and the senior author now is Mark Ball, and Mark Ball is now a young but new surgeon over at the NIH who was trained by Dr. Adam Matwali, who is now a professor and chair at another university in Washington, D.C. And Dr. Matwali was my first fellow. So now it's so fun to look at this list to see. And I was trained by Linehan. So it's just interesting how to see that these are kind of your grandchildren already in the medical term. That you train somebody and they train somebody, so you start to have somewhat of disciples. But what's important of this review is that this series have grown, and we're continually validating what we have been doing. So partial adrenalectomy have now been performed at the NCI alone, and now already 124 cases, 124 lesions in over 100 patients, and there is a lot of information, but most importantly is that there is a very short dependence on steroids. Again, only 10 out of 107. If you remember in my earlier series, it was 3 out of 23. So we're talking about this 10% dependent on steroids. There was only one metastatic event. One patient developed metastases after we removed the adrenal tumor without removing the adrenal gland alone, and solitary. And again, the only risk was having a solitary adrenal, or if you had bilateral or partial adrenalectomy. So I'll conclude my talk more or less on time. So you must expect paraganglioma anywhere in the body. You have to resect paraganglioma, and it should be the goal, if at all possible, especially for the oligo cases, the cases when it's not all over. Adrenal glands are not safe. Just because God gave us two, let's not throw one away just because somebody just tells you that they can't preserve. Partial adrenalectomy provides excellent functional and oncologic outcome, and I hope was able to show you this by low dependence on steroids, as well as low events of metastatic disease, which is extremely low. And finally, at this point, if somebody does have pheochromocytoma in the adrenal gland, partial adrenalectomy should be a standard of care. This is our Department of Urology. We grew it from 2 people in a relatively short time. And I will be happy to take questions later, I guess. Thank you.